Hey guys, Abe Ovadia here. We're here for the podcast at the Work Comp. It's 2023. It's Tuesday. We're having a great time. I'm here joined by Ariel Morales, MD, pain management.
That's right.
He's working in Palm Beach County right now?
Yes, Palm Beach County.
West
Palm Beach. That's right.
West Palm, okay.
Mm-hmm.
And you do pain management?
Yes.
Where did you do your schooling, your residency? Where'd you do all that stuff?
Yeah. So, I mean, a little bit about me. You know, I'm Hispanic background. I was born in Cuba.
Hey, ya tú sabes.
So we got to represent, you know, I went from the grassroots, Hialeah, where we kind of all congregate, you know.
Okay.
And yeah, I grew up, I'm a T-bred. I graduated from Hialeah High School. So T-bred love to all the listeners.
There you go.
And, it was a kind of a weird path to medicine. I initially didn't know I wanted to be a doctor. When I graduated high school, I didn't go to school right away. I wasn't the traditional kind of medical school applicant. I started doing sales, telemarketing. I did really well in sales. I had that kind of human connection that I really enjoyed. And that's what got me back to school. And I got back to school to do an MBA and kind of pursue that avenue. And then I sat down, took a science course, man, and I just fell in love with it. And I realized I kept taking more science. And then medicine really made sense. It was the perfect interface between that human element and that people that I really enjoyed, that people aspect, and then the science aspect. So it's a perfect combination. That led me to pursue a career in medicine. Cool. I ended up going to University of Miami for medical school. So much love. Always. It's all about the U. That's right. And,
I went to FIU. We got in a big fight, I think, our football teams, but either way, it's all good.
One of my best friends went to FIU, man. So we got a lot of love for you guys. Cool. And then, after medical school, I applied and was fortunate enough to get into Harvard. I did my residency at Mass General Brigham. Which is one of the parent hospitals of Harvard Medical School, and stayed on there and did my interventional. So my residency was in anesthesiology, so I'm an anesthesiologist as well. And then I did a fellowship in interventional pain management at Harvard as well.
Oh, wow.
Yeah. I stayed on board.
Was that 2 programs that you did?
2 programs. That's right. That's right. So it's a 4-year anesthesia residency, and then there's an additional year for interventional pain.
It's a lot of schooling.
It's a lot, man.
These people don't understand. It's a lot of schooling.
It's a lot.
Before you really get out there on your own.
Exactly right.
Yeah.
Exactly right. I mean, it's 4 years of undergrad, 4 years of medical school. There's usually a year in between that. So that's already 9 years. Then you go back 4 more years for residency, another year for fellowship. It's a long haul.
And don't let this guy's good looks fool you. He's 40.
Oh, yes.
I got to throw it out there because I didn't believe it. I just turned 39 yesterday and I go, this is BS. I don't believe it.
You look great too, man. It's the Hispanic genes, That's what it is, man. We keep it good.
Thanks, man.
But yeah, I stayed on staff for a couple of years, at the Brigham. I was an associate professor of anesthesia there, and it was a fantastic experience. I learned a lot. And then I came back home, man, to my people, my family's here, and just my upbringing. So it was an honor to come back.
Cool. Yeah. Was that a culture shock to go from not even Miami, but Hialeah to Harvard? Was that a culture shock for you?
I have to say that it was.
Yeah.
I have to say that it was.
It's very, I would assume, Anglo, like.
Very different.
Yeah.
Very Anglo. People there are just different. They're colder. There's not that kind of warmth.
The weather too, man.
That's probably what it is, man. I don't know if there's an influence of the weather. I'm sure there is. But it was a big shock. You had to learn to kind of be a chameleon and fit into certain groups. But I mean, frankly, I had the best experience there. They accepted me with open arms. They were all very curious about my background. I learned a lot from them, So,
how many people thought you were related to Pitbull?
Everybody always said 305. My cell is 305. So, every time they saw that, they're like, Mr. Worldwide.
Yeah, Mr. Worldwide. Yeah, Mr. Miami. Yeah, that's cool.
That's how it started,
Yeah. Cool. So you got the residency program, anesthesia. The other one was what?
Interventional pain management.
Which is can you explain the difference between what people normally consider pain management, like pills, to interventional pain? Can you explain that?
Absolutely. And at the institution where I train, we take great pride in that. That a lot of the management that we do for our patients, number one, it's state of the art. Number two, it's evidence-based medicine, right? So there's research, and there's a component of that that's very important. But most importantly, it's heavy procedural. So in other words, we treat pain ailments with various injections, therapies that are very nuanced. Anything from spinal cord stimulators to intrathecal pump therapy, to various forms of injections, with a lot of different formulations of medication. So everything makes a difference. Everything that you do, depending on what your target is, can really change the outcome of the procedure, even though traditionally you'd view it as the same procedure.
Okay.
But there's nuances to it that I think are very important. And we did a lot of that.
Cool. So you were telling me you guys do facet injections.
Absolutely.
Epidurals.
Absolutely.
Rhizotomies.
Yes.
And then you do some other stuff that I was like, wait, what? Well, you do spinal cord stimulators, which is becoming really popular, or has been popular,
right.
but is seems like more commonplace now.
Right.
And then you said you were doing thecal sac.
Yes, intrathecal pump therapy. Yeah.
Okay.
So, to tell you a little bit about everything, we treat, there's different kind of back pains, for example, and just to stay with the spine, facet injections are geared more for axial low back pain. In other words, back pain that doesn't go anywhere, right? The back has joints that are diarthrial. In other words, there's synovial fluid, just like your knee joints, just like your knuckle joints. Those joints can become sprained, from an accident, from wear and tear, right? From arthritis. And facet injections are really geared towards treating that kind of pain. Okay. If you do well, then you're a candidate for a rhizotomy, which is where we burn the little nerves that go to those joints, and you get relief for a very long time of that kind of back pain. Okay. I also do, like you mentioned, spinal cord stimulation. I think that's very nuanced now. We're learning a lot more, especially with the targets, with the location of where we place the leads, the target cells, the bandwidth, the frequency of the electrical stimulation that we're using. All of that makes a difference, and we learned a lot from the history of, the quasi results. But now when we target the right area and the right diagnosis, we get excellent results with that. Okay. So you really, and then to answer your question about the intrathecal therapy, intrathecal therapy is really a delivery method for pain medication that obviates or limits the need for the systemic circulation of the pain medication. So when you take an oral medication, it goes pass through your liver, it's metabolized, very little gets to the target area. If you have knee pain, for example, when you take it, very little gets to your knee pain, right? It's all metabolized, and there's a lot of side effects that come along with it, and a lot more tolerance. In other words, your body gets used to that same dose of medication, and you're going to need more to get the same effect. Okay. With intrathecal therapy, you deliver it right where the problem is, right? The motherboard, right? The central nervous system. That's where opioids really have an effect. So delivering it there reduces the amount of medication that you need by a factor of 100, sometimes more, depending on the medication that you use. Okay. I use that, to wean patients off of opioid medication. So if you're on very high oral doses, you're going to need a fraction of that with intrathecal therapy. You don't have to, continue to go to the pharmacy, get your medications every month. So it removes a lot of the kind of stigma and negative aspect of patients that really do need pain medication. And they've been on it for a long time. They have a lot of pain syndromes that require that kind of treatment. So this is a good option for them. And in addition, I'm very passionate about cancer pain. And, all of these patients can greatly benefit from intrathecal therapy because at some point, particularly, end-stage cancer, you're going to need pain medication. And this is by far the best delivery method. So I take great pride in that. Yeah.
Cool. So would you consider that a focus of your practice is treating cancer patients?
Yes. It's one of the focuses of my practice, and it's something, like I mentioned, I'm very passionate about. Where I trained, Dana-Farber is one of the best cancer institutes in the world, really. So we did a lot of cancer pain, a lot of palliative pain. And we saw a lot of these patients and helped them out a lot. Not only with the intrathecal therapy, but we do all kinds of things for them, right? Nerve ablations that they need, sympathetic blocks, a lot of different things, depending on where the cancer is, where the pain is being generated, what kind of pain it is. Is it visceral pain coming from inside? Patients that have malignancy in the colon, for example. You can get a lot of pain. There's a lot of different procedures that we do, but intrathecal therapy, I would say, is the base for all of that.
Okay.
So I am passionate about cancer pain, man. I think everybody with cancer should have some dignity in that and have some quality of life. Is the most important thing for sure.
Mm-hmm. Okay, wow. And another part of your practice, you guys treat obviously chronic pain, but someone who's injured in a car accident, stuff like that as well?
Absolutely. And that's a very important aspect of what we do. I mean, we understand the injury focus, the cause of the injury, and really how to treat it. In Florida Spine Associates, we have an excellent group of physicians that are all very highly trained. We have a bunch of guys, like 3 of us are trained at Harvard. We have Stanford, a bunch of Ivy League schools.
Okay.
So everything is very evidence-based, and we treat all kinds of pain from accidents, traumatic pain, not only pain in the spine, even though that's what our name really highlights, but we focus on pain coming from anywhere, a shoulder injury, an elbow injury, various kinds of injuries. We deal with it all.
Yeah. Okay. And your particular office is in where?
My particular office is in West Palm Beach.
West Palm. Do you know the other offices you guys have? You got a lot.
Yeah, we have quite a few offices, actually, all the way from Fort Lauderdale up to West Palm Beach, where I am at.
Okay.
I also work at the Atlantis office off of JFK, Maine.
Okay.
So we really access that hospital as well. We have all of the hospital resources there. One of my partners, Dr. Alam, who's orthopedic spine, he's fantastic. He operates out of that hospital. I see a lot of his patients after. So it's a good group, and we offer excellent care, man.
Cool. Awesome. And so you were talking about axial pain, right?
Yeah.
And that's the difference to that would be what? Radiating pain?
Exactly right.
Okay, going
exactly
up and down.
Right.
Okay.
Yeah. So, axial pain, like I mentioned, is really emanating from various sources, right? The most likely source is soft tissue injury, particularly after an accident, from the jolting of the crash. Ligaments, muscles get strained. And then beyond that, facets can get strained. Just like you sprain your knuckle joint, playing basketball or anything like that, you can also sprain the joints in your back and your neck. And that can generate a lot of symptoms that typically stays there and doesn't really go down an extremity. There's some radiation patterns into the shoulder, into the buttock. But then we classify the other kind of pain. The way we think about it is what we call radicular pain. Okay. And that pain is really being generated by a compression of a nerve root.
I got to tell you, the radicular pain thing, I've had clients tell me, I don't get it, man. What ridiculous? Is it really?
Yeah, it is ridiculous, man.
I don't know, bro. I don't know where they came up with these. We were talking about some of the other things. This guy said he had a torn labia in his shoulder, and I go, you got a torn labia in your shoulder? Are you sure? And he's like, yeah, man, it's bad. I was like, oh.
I think you meant labrum.
yeah, it's a labrum, yeah.
Yeah, that's hilarious, man. And those are the medical terms, these guys name these things kind of funny. But, radiculars from the term comes from the radicular nerve. So that's what we call these nerves that come out of the spine. They're called radicular nerves. So the pain is kind of labeled that way, radicular pain.
Okay, and that's the pain that people describe as I get these shooting pains up and down my legs or down from my neck down to my arms, stuff like that.
Exactly right. And a lot of pain, you may hear the common term is, I have sciatica. Everybody, you hear that when you have pain behind your leg or something, everybody calls it sciatica. And that's a very specific diagnosis. It could be sciatica. But the sciatic nerve is the nerve that is formed by the junction of all those radicular nerves. So radicular pain, you're really describing pain that comes from the spine, like a herniated disc during a car accident, right? These discs can herniate, man, from the jolting of a crash, you know? The disc, the way I always describe the disc is like a jelly donut. So there's a hard outer shell and a soft jelly middle. And once that outer shell is traumatized, that inner soft component can bulge out. That's what we call a herniation, when that soft component bulges out. And it can press on neural structures, nerves and things of that sort. And that causes pain that shoots down your leg or your arm, for example.
Okay. And it's funny, man. Not all, but some. There was a guy who's a chiropractor who decides he's going to manage a pain management group. And he tells me, listen, man, the doctor recommended facet injections, diagnostic in nature. And, my guy just left the group or whatever, but you're going to have to find somebody to do it. And I was like, okay. I was like, facet. And this is when I was a brand new attorney and I had no clue what was what. Yeah. And he says, yeah, they're diagnostic in nature. And I was calling everybody. I don't know what this guy means. The guy didn't even know what it is. Facet injections are, and I don't think the patients understand this too, is they're, and I guess even an epidural is they're diagnostic and therapeutic, right?
Yes.
It's hey man, we're gonna try this one. If it works, then that means we're following the right path. It's related to your facet joint pain, right?
100%. That is exactly right. And that's I think that's a common, misconception. And that's why it's so important to really explain these things to the patients, man, and to build that patient rapport, so that they can really get on board with the therapy. But yeah, essentially facets, the pain that comes from those joints in your back, we just call those joints facets, that pain is transmitted through a nerve. And that nerve is called the medial branch nerve. And in order to really treat that kind of pain, you block the nerve. And that's what we call, a facet injection is kind of a term for it. In reality, it's a medial branch block. That's how we think about it in medicine. Okay. So if you block that nerve, patient goes home, he had terrible pain. 15 minutes after the procedure, after I put anesthesia in there, the pain should be resolved if the pain is coming from those joints. Okay. And then,
for how long?
So that's a good question, So then that's where you got into the whole therapeutic component of it. That depends. If the patient improves, you already got the diagnostic benefit. And in reality, that's all that matters. Because if you don't get the therapeutic benefit, in other words, if it doesn't last more than 24 hours, as long as the numbing medication's there, when the numbing medication goes away, the pain comes back.
It wears off in 24 hours.
It wears off in about 24 hours, sometimes even less. And that's okay, right? That's why some patients don't understand. And they're like, oh, this injection didn't work. But you really have to tease that out. Did you feel better even for 8 hours? Yes, I felt great for 8 hours. That's a positive injection, right? Okay. What that means is that we need to follow up with the long-term fix, which is the rhizotomy or the radio frequency ablation. So instead of numbing that nerve, we cauterize that little nerve. It's only there to transmit pain. You don't need it for anything else. And it doesn't grow back for a very long time. And you get relief for a very long time and really give your body time to heal, give those joints time to heal, particularly after a motor vehicle accident or a traumatic event.
That's interesting. I never thought of that. But, I have a lot of people, they told me it'll last like up to a year or maybe 2 years if I'm lucky. Yeah. And then it's going to regrow, regenerate. Right. But they never mention what you just said, which is, it's going to give you, during that time, your body's going to heal as well. And you're going to live without that pain and you can maybe like restore function and
exactly
stuff like this.
Right. That's your opportunity really, man. When these patients improve and get better, to strengthen your back, to do some good therapy, to continue your range of motion exercises and really give your body time to heal and the ability to heal. If you're in terrible pain, you're not going to be able to do anything, right?
So you're not going to walk, you're going to gain weight,
exactly.
You're going to get worse. Okay.
So this is really like a bridge to a better outcome, which is healing of your body.
Wow, that's I've done a bunch of these with pain management. I've never had anybody explain that to me, where it gives you time to heal and maybe restore some things in your life. Maybe get to the gym or at least go for a walk or something. Just strengthen. Maybe do PT, right? Like strengthen all the muscles and stuff like that.
And that's the key. And I always tell my patients that, now that you have some form of temporary kind of solution, now you give your body time to heal and the things that your body needs to heal, right? Which is the therapy, staying active, range of motion. Okay. All that good stuff.
Wow. That's incredible. Okay. So Doc, tell me, one of your patients, can you just give us a story maybe about one of your patients and some of the benefits they had or some story that they gave you about how it improved after a procedure?
Absolutely. So, one patient comes to mind. This is an older gentleman, had, multiple revision surgeries of his spine, complicated by chronic intractable pain that really didn't get better. He was on high dose opioid medication, a bunch of different kind of medications.
So he had a bunch of surgeries to his back.
Exactly right.
Still having pain.
Still having terrible pain. Quality of life was terrible. He also had damage to his peripheral nerves. So his nerves in his feet, what we call peripheral neuropathy, that causes burning, stinging. I mean, he had a terrible quality of life.
Neuropathies where it feels like a bunch of ants biting your feet constantly,
exactly right.
or like if you fall asleep on your hand and your hand wakes up super numb.
Exactly right. And burning and just terrible sensations. And it kept him up all night. And that's, one of his primary complaints. And he came to me and he's like, Doc, what do I do? I've had multiple surgeries. Nothing's helped. I've had injections. Nothing's helped. And he was an excellent candidate for what we talked about, that intrathecal therapy. So I did a trial for him where I just put a little bit of medication where the target target is, and he had excellent benefit. He came back, he said, Doc, I felt better than ever. I had my first night's sleep in as long as I can remember. I want to proceed. So I put in the intrathecal device, and he's been doing so good. He went to North Carolina, which was one of his dreams, with his wife, and stayed in a log cabin and did things that he had been planning and had been unable to do for years.
Wow.
So it was very satisfying to me. He's like, my neuropathy, that sensation in my feet is virtually gone. So he's able to sleep at night. He cut out the oral medication completely. I mean, it's a really excellent success story, man, that just motivates me to keep going.
That's cool, man. It's those stories that keep us doing what we do and keep us passionate about what we do. So
absolutely.
That's cool. Explain this device to me, because you said pump. So is this like a 24-hour device that they wear?
Yeah, so that's a great question. It is. That's a great. Yeah, so it's we call it a pump because it administers medication continuously. So in other words, constantly giving medication at a defined dose that we plan ahead of time very carefully and monitor very carefully, and then so they don't have to take the oral medication. In addition, they have essentially a cell phone where they can, give themselves an extra dose of medication if they're going to go out for a walk, go play golf, something that really limits them, right?
Okay.
And they give themselves an extra dose of medication that we coordinate ahead of time. Everything is done very scientifically and safely.
Okay.
And then they can do that. The device is implanted subcutaneously, so under the skin and soft tissues.
Okay.
Usually on the side of the abdomen.
Okay.
And then there's a small little catheter that's what administers the medication in the back, in the spine.
Oh, okay.
Right? So it's a very simple surgery. It's not long, and it's a day surgery. Patients come in and they go home, probably about a couple of hours after the procedure is done. So very, very straightforward in that respect.
Oh, that's awesome. Yeah. A lot of people think these surgeries are, super complicated, and, I'm going to lay in the bed for a month afterwards. And I go, listen, this guy does this. He does 5 of these a week for years.
Yeah.
And by the way, he did all these years of school to get there. So it's not like, he just got his McDonald's degree and here he is now, doing these procedures. I go, this is what they do on a regular basis.
Yeah.
It's no different than something that you do in your life over and over and over again. You're good at it,
Exactly right. Exactly right. Whether you're, a mechanic, whatever you do, you've practiced your trade, you've perfected it, if you're good at it, right? And in medicine, there's always that standard that you have to be good to move on to the next level.
Yeah.
So, absolutely. It takes a lot of training.
Yeah. Awesome. Yeah. People they're always worried about, in my opinion, they're stuck in this mindset from 20 years ago where someone gets a back surgery and they're in the hospital for a month. It's like, no, nowadays for most surgeries, you go home the same day. If maybe you're a high risk, elderly, diabetes, things like this, maybe you stay in a hospital for a few days to monitor, right? For most of these things. But most of your procedures are same day.
Same day,
right?
All of my procedures are same day, I would say. And we've learned a lot, man. Like you said, 20 years ago, we thought that keeping the patients in bed was a good idea. Now we know it's not a good idea. We want these patients moving as quickly, as soon as possible, prevent complications that are not even related to the surgery, like deep, clots in your legs, things that can get unnecessarily complicated by keeping patients sedentary. You got to get moving. The body's meant to move. We were meant to walk. That's in our genes, in our DNA. Wow. And that's what we have to foster in medicine,
Cool. Awesome. Sure. And that's a great story about that guy. I like that. That's cool. Cause sometimes every now and then I come across people who are just, they're just miserable. They did the surgery they were recommended. They did the procedure they were recommended, and they're just not getting any better. And sometimes you're like, man, I don't know what to do for you. You know,
Right.
I'm sorry, like, something I could do. But that's a great story. I like that story. Thank you. So for the people who are watching, they want to know more about you. What do you like to do outside of medicine? What's your passion? What do you like to do for fun?
Yeah, that's a great question, man. So, I mean, I in another life, I always say I was going to be a musician. You know, I play guitar.
Oh, okay.
I'm very passionate about it. Since I was like 12 years old, I've been playing guitar. My grandfather was involved in the music industry. So it was really kind of my upbringing. I was that kid, you know, in the talent show, the rock band, all that stuff in high school. So it was a lot of fun. I still play. I play a lot. You know, classical guitar, electric guitar. I play it all. I enjoy it all.
Damn, we need him to bring his guitar so we could get it on. What do you?
I'll rock out, man.
Yeah. Like what kind of music do you like to play? Like what?
I could play anything, you know, anything from classical music to, I mean, I'll play a good Star Spangled Banner for you guys, you know, kind of Jimi Hendrix style.
Okay.
I love it all, man. I really do.
Stairway to Heaven.
Oh yeah. Stairway to Heaven, all the classics, man, you know? And then for the kind of classic metal listeners, I play a lot of old Metallica stuff, which is some of the best rock music. And technically challenging on the guitar. It's awesome, and it sounds so good like live. It's very different than hearing it on a record. When you hear somebody play it in front of you, you're like, whoa, that's really cool.
Nice,
so,
that's cool.
We'll jam out, man. Bring it up. I'll bring it.
I love me some Metallica. I don't look like it, but I like Metallica. Sandman. I grew up on that stuff. Puppet Master.
Man. It's a classic. They're classics, man.
Yeah, cool. Yeah. Guns N' Roses. Welcome to the Jungle. It's like,
you got to hear me play that.
It's
fun.
Okay, there we go. All right, cool. We got it.
Yeah,
we'll do a little talent show at one of these things, and we'll have him come with the guitar for sure.
Let's do it, man.
I'll bring my scuba gear and just like breathe with the regulator on outside of the water or something. I don't know.
You got to teach me how to scuba, man.
Oh, dude, it's fun. Yeah. It's fun.
I love the ocean, man. I love it.
It's beautiful. You know? It's beautiful. I got to show you some of the videos I got. It's like a whole new world. Just like the Little Mermaid said, it
really is. Yeah. Well, look at that. It's poetic. My name Ariel. You know, it's a whole new world, man.
Yeah, cool. So, awesome, man. That's great. And looking forward to seeing more of you. We just met at the WorkComp conference. That's what I love about this conference is you get to meet new people.
That's right.
It's an informal setting. You can just meet people and build relationships. And I'm really looking forward to it. Thanks for being on the podcast.
Likewise, Abe.
Thanks for coming by today.
An honor and a pleasure. Thank you.
Thank you. All right, thanks.
All right.